take you through our 6-point blueprint, essentially a roadmap of how we get from where we are now to where we want to be as a system. This was developed in the Lancashire South Cumbria system and has informed the national programme. The first part in our 6-point blueprint is to baseline, to get an understanding of how activity is currently managed in all providers across the system, to really understand how our system functions, identify any particular known bottlenecks or variation in patient pathways and understand the rationale for this, develop clinical consensus utilising the data and best practice evidence to really determine what should be the optimum patient pathway for management. We also in this phase need to agree a system approach to managing patients and a single waiting list, including the management of any COVID related issues or impacts on the pathway. And start to map and evaluate how system provider PTL waiting lists currently operate and identify any localised approaches to waiting list management and the rationale for these. The idea is at the end of baselining the system, the output would be a common system pathway. Point 2 in our 6-point blueprint is looking at waiting list validation. So really understanding the data, trusts sharing data on their current PTL and making sure that all currently received referrals are added to the PTL. Commencing a data cleanse to identify any PTL duplicates or rogue entries or anomalies. And then developing and implementing a communications plan with patients to really understand waiting list validation and to avoid short notice listening or unreasonable offers. Validation also requires the setup of a mechanism for clinical review in cases where patient clinical status might have changed whilst being on a waiting list. The idea of waiting list validation is really to get a fully system validated specialty waiting list. Point 3 in our 6-point blueprint is to implement a single system waiting list. This will require understanding data flows, establishing data safe havens, agreeing the mechanism of transfer for data to really get that system overview and a system level waiting list. Point 4 in our 6-point blueprint is to really gain an understanding and overview of system performance. So really identifying any key areas, understanding performance against some of the national targets, understanding any variation and gaining an understanding of the impact of COVID on any 52-week wait patients and backlogs. We also in this phase need to gain a system consensus on any priority areas to target across the system, really reflecting risk, patient harm and any high volume significant outlying positions, and develop system recovery plans for these priority areas. It's also useful to be mindful of understanding any system risks and issues through forecast modelling of patient RTT to identify the system capacity required to manage the current waiting list demand. The output of this phase to be a system level performance monitoring and reporting function. So this is really getting a true understanding of the system's capacity through mapping, looking at consultant and medic job cards, identifying any variation and standardising where possible, and establishing any mechanisms that might be required for provider allocation and ongoing performance and activity review. By really gaining that system consensus on how activity will be managed in the system and flowed through system providers, matching the complexity of patient need with a suitable provider. In this phase, it's also helpful to identify any pressure points and capacity pockets across the system to match demand, and complete data modelling and capacity and demand analysis to determine system activity flows, for example to specialist sites, matching expertise and capacity. And lastly, point 6, in our blueprint is really to get a full view of elective system management and implement whole system elective management. This is really about understanding dynamic referral management, establishing system priorities, understanding whether it is helpful to run a system choice menu, and really getting a full validation and workup on a system footprint. So really looking at how the system comes together to operate truly as a system. We're at the beginning of our work in this area, but we've already seen a number of benefits from operating in this way. We have a really improved understanding across the system of some of the challenges faced by our partner trusts. We've forged significantly strong relationships as a result of this work, really understanding people's positions, understanding some of the challenges that they face, and also gaining a consensus around how things should be delivered as a system. We definitely better understand data and use the data to inform data-driven decision making across the system. And we've already been able to share some best practice on pathway management. System partners have also been able to implement mutual aid activities, which have definitely helped the resilience within the system and also the collective performance of the system. So that summarises our 6-point blueprint of how we get to whole system management of elective care. As stated before, this is a blueprint for delivery, and we recognise that there are a number of activities that sit under each of the areas that we've outlined. We also recognise that whilst there are key activities that do need to be undertaken, one of the main activities that are required to make this area successful is really to develop relationships across the system and win hearts and minds to allow effective implementation.
In terms of data use initially, we found that there was quite a lot of data around the NHS landscape that we could quickly pull upon and utilise in maybe a slightly different form or through a different lens in order to inform some of the early discussions around pinch points across the Lancs South Cumbria system as a whole, understanding that from a broader perspective of the 4 providers within the system and the nature of our out of system activity. And bringing that together then with the aims and objectives of the programme as it looks to unfold, and really identifying then what was needed in addition to that. And I thought I'd reflect actually on, rather than how data is informing our approach rigidly, let's look at this as how the world of data is informing our approach. So what does that mean? So a lot of colleagues on the call and those that we're working with will have heard a lot around the population health management work that's been becoming more and more prevalent over the last couple of years, and how we are all working very hard to ensure that linked data is available to inform those population health management programs and approaches. So in terms of the BI and data community that have been involved in that work and taking those programs forward, there's a real key message that has come through a lot of that national collaborative work, which is that really PHM is around 10% data and 90% is about the people and the culture that data relates to, and of the organisations that data helps to run and to inform on a daily basis. So through the PHM context, perhaps there's more a more immediately tangible assessment there of how 10% data, 90% people comes to life. But I just wanted to reflect back and think, actually, you know, that learning is equally relevant as our journey into system working takes hold and we move forward. What do I mean by that? Okay, so 10% data, 90% people and culture. In this context, the people are the colleagues in the system that are working more closely, more collaboratively for the first time. The culture is that of, significantly sized hospital trusts with custom and practice of working that goes back a long time. And whilst that on the surface they all may appear consistent through the lens of some of our national data sets, then we all appreciate, I think, that underneath that there's quite a variation and nuance relating to how our colleagues are all trying to constantly effectively deliver services, improve quality, and make a better experience for the patient. So our reflection locally then, being aware of the work being undertaken on the validation programme, reflecting on some very recent learning in terms of our mobilisation of other responses into the system around particularly COVID response in hospital, sit reps, primary care, out of hospital, and bringing together a plethora of different information sources. We felt that a really powerful thing to do would be to supplement and to enhance really the system integration theme by establishing a collaborative BI provider leads group to supplement and support the work of the directors of operations across the system. So the purpose of that is really to underline the value and the importance of understanding the culture, the people behind the data, but also, in fact, to make sure we make really valuable use of any new data collection or interpretation that we embark on through this journey. And that allows us, in parallel to the work that's already going on in the start of the programme in terms of validation, moving on to clinical review, understanding the scale of the problem, the pinch points in our system particularly. What it enables us to do is foster that discussion and start to explore some of the more subtle nuances in terms of what our directors of operations might need to inform the next part of their journey. For example, we're undertaking some understanding now as to how our different trusts might group procedures together for theatre settings, for example, or for clinician lists. But I do think it's really important to not lose the concept of linking our soft data as well.
Asked to talk about the national approach to waiting list validation, and I guess first of all what I would like to acknowledge is that a lot of the work that we've started to mobilise actually comes from the slide set that Claire shared with you all at the very beginning. You'll have seen the 6-step process that she outlined there, and certainly the second stage, which was validation, was really where we sort of joined together to get this piece of work really mobilised. So the national approach has been sponsored by the National Incident Response Board, which was obviously set up as a result of the COVID-19 pandemic. And clinically, this has been taken through to final approval by the exec at NHSE, by Professor Chris Moran. Chris has done some very extensive discussion and negotiation with all of the Royal Colleges to gain their support for this piece of work, which I think for all of us embarking on this journey is really vital, because we need to be completely aligned with the Royal Colleges, because this is fundamentally a clinical validation. So the colleges, right through from primary care, physicians, colleges of surgeons, and additionally the patient, all of the relevant patient forums have been engaged with regard to this process. The overwhelming feedback coming from this process is that this was never going to be, and never will be, what I would describe as an algorithmic exercise. And that is where you basically put the patient's details into a computer system and it generates whether the person is a category P1, 2, 3, or indeed can't have the procedure. the approach that's definitely being advocated and will be advocated is that a conversation has to formally take place between the patient and the appropriate clinician, and that a shared decision-making process is undertaken with integrity. I think the overwhelming feeling was that we've got some very anxious patients out there, anxious for a whole range of reasons, whether it be physical issues, whether it be compromised income, and so we have to do this with both respect and sensitivity. The prioritisation is going to be split into 3 areas, and Claire already alluded to that. Next have developed a system that in essence can what I would describe as sift the waiting list, so that a consultant's waiting list can be presented to the team based on whether it's procedure or site. And then in effect, after a conversation, patients are allocated a specific disposition. Now, the dispositions will be based on whether they are an outpatient waiting for a diagnostic procedure or waiting for an inpatient procedure. For an inpatient procedure surgically, that will be using the Royal College guidance P1 through to P4. But a further disposition has been identified of P5, which is those patients who have chosen to defer their procedure as a result of COVID. And the waiting list guidance is currently being refreshed to reflect that. The letter, a gateway letter, will be sent from the NHSE Chief Exec's office, signed by Amanda Pritchard. Hopefully that will be arriving in trusts, all provider trusts today. And the intention is actually to get certainly the surgical waiting list. So those patients who've got, they won't have a decision to admit, but will have a decision to list for procedure, to have that waiting list validated by the 23rd of October. Now that is a really tight time frame and a huge ask of trusts, but equally what we are seeing is now that patients are deteriorating in condition, and so it's really important that we've not got people in that place on the list. Fundamentally, this process is designed to reduce variation across systems. So in essence, it allows patients to be treated in clinical priority order as opposed to waiting time order. And that goes back to Claire's point that then it allows you to really start to reduce variation, and maybe hope that people who are not already compromised become further compromised.
Thank you to Sue, and thank you to Glyn for their insights there into something that I would summarise as the need to work together, as systems. Martin Stevens.
Hi there, afternoon everybody. Thank you for that. It was really useful to hear what the experiences have been elsewhere. I suppose the question for Claire really, because I think you started off right at the beginning of saying how providers in the system were working pretty independently of themselves, and how did you bring those guys together? Because that's certainly something we're struggling with in the Black Country, is bringing those providers to work together in a bit more of a cohesive way.
So quite interestingly, Martin, our system is quite well structured from a system working perspective already. From a commissioning perspective, anyway, we've got a single ICS executive across the system. In terms of engaging some of the providers, it was really bringing them together in those forums, and a lot of it had come out of COVID, if I'm honest. We had a really robust command and control structure in Lancashire and South Cumbria, and a number of those trusts were engaging in those anyway. And so when we had the phase 2 and then phase 3 restoration recovery letter, people were already live to this is the ask and the real focus on we need to work as a system, and these are some of the potential opportunities and benefits of working as a system. We found that, you know, as we kind of grapple with some of the issues in trying to deliver this work, there are those kind of relationships that have just been really forged more from managing some of the challenges and, you know, having those discussions around how do we approach things. I think sometimes it is kind of getting, I would say getting in a room, but getting on a Teams and really looking at, okay, these are some of the issues that we need to deal with. We know where we've all got to get to. How do we do that? And how can we support each other in this time and as a system? Because ultimately, we've all got the same goal of wanting to deliver really well for our patient population. And that's really what harmonises people across a system. So it's focusing on that and being really clear about the challenge and recognising some of the strengths and weaknesses and getting some of that, dispelling some myths and getting some clarity about some of the challenges and pressures that individual trusts are seeing really during this time. That's what's really brought us together and got the trusts working in a more cohesive way. And I think even from our responses to kind of phase 3 at the moment, there's been a huge recognition that actually, yeah, we do need to operate in this way, and this way is going to hopefully give us some of those benefits as a system and help us to deliver better for our population.
Thank you, Claire. Neil Walker from Solihull.
Thanks for organising this sort of session, which is much appreciated. I mean, I think I found. I mean, Claire's presentation and in terms of the sort of 6 stages, that resonated with me in terms of sort of the journey that the Birmingham and sort of Solihull sort of system has been and is sort of going through. We've got a fairly good picture of what the total capacity is. What we've got to do, the challenge is utilisation sort of optimisation. It's one thing to have neat plans for using all the theatre and endoscopy capacity that's available. It's another thing to actually really have efficient utilisation of that capacity. And I think it's been interesting with our independent sector sort of support capacity, which we've got quite a lot of across Birmingham and sort of Solihull, to actually sort of look over the last sort of 6 or 7 weeks, how well is it actually being used? Are there particular specialties, particular trusts that are habitually not using it as effectively as they could, and what are some of the other reasons for cancellation of individual patients or lists? So this has been a really helpful session for me. Thank you.
Thank you, Neil. Thank you for your reflections there. Sue, I think you want to come in and contribute.
Yeah, if I may, and I guess it really builds on what Neil has said. So, in terms of the I guess the information that will come out with the letter and so forth, we've developed a really, I think, robust sort of like infographic around shared decision making to support clinicians. But also we've worked with quite a number of groups, for example, developing prehabilitation advice as well, given the really important emphasis on optimising people before they embark on a surgical procedure and the inherent risks there. And that, I think, has been really well received by the Royal Colleges. Because obviously they're looking at this in a much more holistic way. The programme that I'm leading links into the adapt and adopt work streams. So it's underpinning outpatient endoscopy, CT, MR and theatre recovery, and some support to cancer as well. And we've made sure that we're not duplicating in those areas, but actually it's seen as an enablement programme, because the final aim of the Adapt and Adopt programme, which is where it started pre-COVID, was the development of elective hubs, which is why Claire's piece of work is so fundamental, because I do believe that will be adopted as the national strategy moving forward. So it's a really important piece of work that she's developed there.
Derek, I just want to say, obviously we've set out our approach and our blueprint, but we recognise that that's the high level roadmap, and actually some of the detail underneath that are projects and programs within themselves. And I think there is something about us really recognising a lot of those stages to really implement them and implement them well are a real hearts and minds piece across the system. There are some fundamental challenges ahead of us in the delivery of this work, not least kind of really peeling back how different kind of activities, different specialties deliver care to patients, and really, move into how we get that consensus across clinicians around how to manage certain patient cohorts. That is going to be a real challenge, and we absolutely recognise that. As a CSU, we've provided a lot of support into the system, be that kind of programme management, facilitating those conversations, as well as utilising our, BI capabilities and things across the system. And there are a lot of different facets to this work, and it's not an easy feat. And I know that anyone that's working in this space will know, this is really challenging, but obviously it's going to be very rewarding if we see that we can kind of exploit those opportunities and really start to drive kind of improvement and efficiency across the system, and ultimately deliver better care, as we've said already, to patients.
Claire, before I bring Neil in, Claire, your comments there, and your earlier comments, just reminded me, resonated with the fact that systems, we're certainly involved in the Lancashire South Cumbria system, have got an integration piece going on already around COVID-19. So, as we know, Seamus McGeer from the CSU now working with both commissioners and providers, with a single information system, single use of reporting and data. I know Glyn's been heavily involved in this, helping the system understand where the pressures are coming from COVID-19 and the impact that that's having on capacity. It strikes me that that very similar approach, which is almost entirely aimed at the emergency element of the service, the non-elective element of the service, and how we react and manage to the pressures, could be equally applied to the elective side of the equation as well. And wouldn't it be great, listening to Neil and Martin, if a single BI system was able to drive the response to the elective challenges as well as we are driving the response to the non-elective challenges? The needs are different, but just as important for those people involved.
It's been really interesting to sort of see in terms of sort of not just the work that the Royal College has done, which we've been trying to sort of build on more recently, but actually how evidence, the principles as well as the detail of evidence of national evidence-based intervention policy development work is actually starting to sort of dovetail into surgical prioritization. And so one example, and so the way in which our certainly University Hospitals Birmingham views these policies, both national and local now, has actually moved on quite a bit as something that supports the system rather than something that's sort of, if you like, CCG or sort of commissioner imposed.
First thing I'm going to say is thank you so much for taking part. Thank you to those people who've contributed both from within the agenda, Midlands and Lancs, Sue, Neil, Martin, etc. Just really great to have the discussion. This is one of a series, so there will be more of these webinars coming out. We're aiming to do one a month.